Welcome everyone to today's webinar, live from San Diego from ID Week. We're going to talk about Procalcitonin today, a biomarker for assessing patient prognosis, response to therapy, and guiding antibiotic duration in patients with infection, with sepsis, with respiratory infections. As for potential conflict of interests, you see my potential interest and conflicts here on the slide. And I'd like to start with this first slide, showing you a big white shark, a big killer, as you may think, but sepsis actually is the much bigger killer. And so while for the shark, we have a very good biomarker and know when the shark is in the water because his fin is going to show above the water, we also need a good biomarker for sepsis. And so within the next slides, I would like to show you how PCT can be used as a marker for sepsis and help us to better manage patients with sepsis. Before we start with the presentation, I'd like to ask a question to see how many of you are using PCT in your institution for diagnosis and assessment of sepsis. Okay. So yeah, so about 2/3 of you are using PCT in your institution for sepsis. That's very good. And so let me ask you another question. Is PCT used for antibiotic stewardship, antibiotic management in your institution? Please also provide us with a response. Okay, so about half of you are using PCT for antibiotic management. So I think that's very good, and this is really where I see most of the potential of PCT. So as you all know, sepsis has been a very difficult topic of research and studies with a lot of trials reporting negative results. And really we were not able to bring in new drugs to improve sepsis care. So currently, we all go like a step back and to the most basic concepts of sepsis, which we know are important to improve patient outcomes. So first, I think recognition of sepsis is really instrumental because that's when our sepsis care starts. So early recognition of sepsis, but also early rule out of patients without infection. That's a very important first step. Second, one, we have established the diagnosis of sepsis early. Resuscitation with antibiotics and fluids is really a key step and has shown to improve outcomes in patients. And of course, diagnostic management and also supportive management in ICU, including other microbiology tools, are very important then to correctly further manage the patient and improve outcomes of patients. So today I would like to talk how PCT can help us with these challenges, starting with the early recognition, the initial resuscitation, antibiotic decisions, but also in the supportive management of the patient, particularly as a tool to monitor patients and to help us decide when to stop antibiotics. So I'd like to focus on 3 important questions. First of all, I'd like to talk about prognosis. So does PCT provide prognostic information? Second, I'd like to talk about antibiotic decisions. And so here I'd like to give you 2 examples how PCT can be used. So the first one would be PCT, if it's negative, it has a very high negative predictive value and helps us to rule out bacterial infections in patients at low risk. So let's say a patient with a bronchitis type syndrome, a patient going to the GP or the ER. Second, in a patient with an established diagnosis of sepsis or pneumonia or systemic infection. So in this case, PCT is very helpful for monitoring of the patient and helps us to early discontinue antibiotics and thereby reduce exposure to antibiotics. And lastly, I'd like to talk about clinical outcomes associated with PCT-guided care. So before we look into the clinical data, I'd like to show you a cartoon demonstrating how PCT is regulated on a cellular level. So you can see bacterial infection induce a strong cytokine response. Cytokines such as interleukin-1 beta or IL-6, they are very strongly increased and they induce a PCT increase in all cells of the body. So during a bacterial infection, we find an increase in PCT in the body of our patients. And we've also found other markers being increased during infections and inflammation, such as C-reactive protein. However, if we have a patient with a viral infection, then we have a different type of cytokine response. So in these patients, we found more interferon gamma and other cytokines. And interferon gamma has been shown to block the upregulation of PCT. So we believe this makes PCT much more specific for bacterial infections and helps us to differentiate between viral infections and bacterial infections. So this is a nice cartoon, but does it also work in real-life patients? So I'd like to show you one study that has compared patients in the intensive care unit with a clinical syndrome of pneumonia during an influenza season outbreak. So on the left side, you can see patients that had influenza pneumonia, and on the right side, you see patients with influenza pneumonia plus a bacterial co-infection. And so very clearly, you see PCT being regulated in these patients with the bacterial co-infection. And so when the investigators of this trial looked at the value of PCT to differentiate between viral and bacterial infection, you see the area under the curve of 0.90 shows you that PCT has a pretty good value to differentiate these two clinical syndromes, which clinically look very much alike. Now, this is just one example, and of course, a lot of other studies, observational studies, have looked at the value of PCT to differentiate between typical bacterial infections and other types of infections. So I show you data here of a recent meta-analysis that has included 30 different observational studies and a bit over 3,000 patients. And so all these little dots you see here are area under the curve estimates from these different trials. And so you see, depending on the gold standard, on the patient population, these area under the curves were somewhat around 0.85. So this shows you that PCT has a pretty good value in differentiating bacterial from non-bacterial disease. However, I think it's also important to realize that PCT is not perfect. So the area under the curve is not 0.99, so it's not a troponin. So how can we use a marker that is not perfect? And I think here it's very important to realize that we need a strong clinical assessment combined with PCT so we can really make it work. So PCT has to be used in conjunction with clinical assessment. So we have to first establish the pretest probability, and the pretest probability is established based on our clinical assessment. So if we have a patient and we assess the risk of having a bacterial infection, and this risk is low in our opinion, and the PCT level is low, then our post-test probability is even lower. And so PCT helps us to establish, or in this case, to rule out bacterial infection in a patient. So we always have to use PCT in conjunction with clinical assessment of the patient. And we should not see PCT as a gold standard for infection, but as an additional tool that helps us to better manage patients with infection. So let's move to our first question. Does PCT provide prognostic information? And to answer this question, it's important to really look at the kinetic of PCT. So you see that PCT, that's the blue line in this slide, increases within about 3 to 6 hours upon infection onset. it has a peak after about 12 to 24 hours, and it shows a steady decrease of about 50% every other day if a patient responds well to therapy. Now, importantly, if a patient does not respond, we don't see the decrease in PCT. So the kinetic is very important when looking at a patient, and using PCT as a monitoring tool gives us a lot of information about the patient's course, about his prognosis, and whether or not he responds to our initial antibiotic management. So these are data from Geneva, and you see on top sepsis patients on the left with green. These are sepsis survivors, and on the right side in red you see sepsis non-survivors. So clearly in all these patients you see an increase in the initial PCT level. So if you have a high initial PCT level, it gives you the information that a patient really has sepsis, that he's infected, that he is at risk. However, more important than the initial level is really the course of disease. So if you see on the left side that PCT drops after 2, 4, 6 days, this is really a good sign. And even though the patient may be very sick, the patient is responding to therapy, and eventually there is a resolution of illness. However, as on the right side, if PCT doesn't drop and shows some sort of plateau, then that's usually a very bad sign. So really, it's not so much on the initial PCT level, but it's more the kinetic over time that gives us the most information. And on the bottom part, you see as a control group patients with a systemic inflammatory response syndrome with no infection. And so clearly in these patients, PCT levels are lower compared to the septic population. We have recently completed a large trial within the US. You see 13 different sites and more than 800 patients. And this trial, the MOSES trial, was an FDA trial to approve PCT as a monitoring marker. And so the hypothesis of the trial was that the kinetic of PCT over 3 days would provide prognostic information beyond that of regular information we have in ICU patients, so beyond, let's say, Apache score, SAPS score, SOFA score. And so the study proved to be positive, and we found that if a patient is not able to clear his PCT levels by at least 80% over 3 days, the mortality is more than doubled in these patients compared to patients that show a nice decrease over 3 days by 80% or more. So this study proved the prognostic value of PCT in regard to sepsis patients. Now, I think prognosis is important in the patients. But if we get prognostic information, of course, then the question comes, well, information, how can we change the management of the patients? And so I think antibiotic management comes into place. So let's talk about antibiotic decisions, how we can use PCT as a tool for antibiotic management. So antimicrobial stewardship, has really gained a lot of attention. And you all know Sir Fleming, who has been a pioneer in this field of penicillin. And he also said many years ago that, morally, everyone that uses antibiotics is responsible for using them correctly. And if we overuse them, of course, we have to mess with antibiotic multi-resistance. So for antimicrobial stewardship, there are 5 rights: the right drug, the right patient, the right dose, the right route, and the right timing. And so particularly the right timing, I think, is a very important question. And while we know in sepsis, we have to start early the treatment of our patients, the question is really how long do we have to treat? Because if we treat not long enough, we are scared that the patient will have a relapse of infection. If we treat too long, then the patient will suffer from side effects like C. diff infection and other problems. So really, finding the right moment to stop antibiotics, this is something very challenging for our everyday clinical patients. And of course, antibiotic stewardship is also in the 2020 agenda, and it's very important to reduce the incidence of C. diff and other antibiotic-related side effects and complications. So we recently finished a meta-analysis together with the Cochrane collaboration, where we looked at randomized controlled trials that used PCT for antibiotic decision-making. So all these trials had a similar setup. I would like to show you in this graph how these trials were set up. So on the left side, you see the control group. So all these trials had a control group where physicians were in charge of antibiotic management. Now, in the intervention group on the right side, it was also physicians that were responsible for antibiotic management, but the study investigators provided physicians with the result of the PCT assay. And with the results, they also provided them with a recommendation regarding antibiotic management. And you see, it's not a yes or no answer, because PCT is not a perfect biomarker, but it's more like a grayscale biomarker. So the idea of the trials was really to say, if PCT remains very low, so let's say lower than 0.1, then the chance of this patient having a bacterial infection is just very, very low. So the recommendation is not to use antibiotics, or if the patient is treated, then that antibiotics can be stopped. And you see, this is a very strong recommendation, and the higher the PCT level increases in patients, the less strong is the recommendation. And if it's higher than the cutoff of 0.25, then the recommendation is really to use antibiotics, but to also monitor PCT and stop antibiotics once PCT has come down to normal levels. So I think it's important to realize that these studies didn't compare PCT-guided care versus a control group, but they compared really a physician with PCT to a physician without PCT. And I think the clinical component is very important when we use this marker for patient care. So just to give you an idea about this meta-analysis, we screened almost 1,000 titles and came up with 26 different randomized trials and more than 6,700 patients. All these patients had respiratory tract infections because this is the main focus of this analysis. So in this meta-analysis, there were two different types of trials included. One of these types is more patients in lower risk settings. So let's say patients in the emergency department, patients going to the GP, patients with maybe bronchitis, COPD, or pneumonia, but without sepsis. So for these patients, the main focus of PCT-guided care was really on the initial evaluation of the patient. And you see the cutoff of 0.25 was used to argue for or against antibiotics. Now, when you look at this, at a typical patient that will be included in the trial, I'll give you an example here. So you see this is a 66-year-old male patient. He's a smoker. He comes to the ER because he has a 5-day history of cough, yellow sputum production, and he tells his GP, well, I feel feverish. I always get from my GP an antibiotic if I have an episode like this, so please provide me with an antibiotic. So you do a chest x-ray, you don't find an infiltrate. You can do cultures, but chances of finding something in cultures, even if he had an infection, is very low. And of course, you can do a CT scan, and there you probably will find a little bit more inflammation. But the question is really, do we think this patient needs antibiotics? And I think all clinicians here would agree that no, this patient probably just has a viral bronchitis and doesn't need antibiotics. But still, chances are very high if this patient goes to a GP or an ER that this patient will come out with a prescription of antibiotics, just because there is uncertainty around the diagnosis, and we don't have really a gold standard to be very sure about the diagnosis of this patient. So the trials ask the question, well, if you have just a clinical evaluation, or if you have the clinical evaluation and you provide physicians with the PCT result, what's the effect on the antibiotic consumption in such patients? And so here you can see the effect. The The blue bar is the control group, the number or the exposure to antibiotics in the control group, and the red bar is the Procalcitonin guided group. And you see that by the introduction of PCT, we have about a 2/3 reduction in the use of antibiotics for these patients, mainly by not treating a lot of these patients. So while in primary care or bronchitis, you have about 60% of patients being treated, PCT-guided care reduces this amount to about 20%. So let's move to another patient example. So if we have a very sick patient, a patient with sepsis, a patient going to intensive care. So here you see the cutoff is a bit higher, it's at 0.5. And it's not so much on the initial evaluation of PCT for antibiotic usage, because if you have a high-risk patient, we all agree this patient needs antibiotics, but it's really more about monitoring and about stopping if PCT drops below the 0.5 cutoff or by at least 80% from its peak value. So I give you another patient example. So you have a 55-year-old female patient. She's a never smoker. She comes into the ER with a non-productive cough. She has chills. She has low blood pressure, 90/70, and she has an increased heart rate of 115. So I think here we all would say, well, this patient is probably going into sepsis. We know there is still a very high mortality, so we need to really treat this patient right away. But here the important question is then, well, how long do we treat the patient? Do we use individualized treatment duration or just fixed doses? So when I went to medical school and read my textbooks, it was written that for pneumonia, a course of 10 days should be used. So while we use fixed doses of antibiotics for many infections, we now try to be more individualized in regard to the treatment durations. So if you have a patient responding well to therapy, he may only need 3, 4, 5 days. But if a patient is not responding well, he probably needs longer courses. And so the advantage of using a marker like PCT in such patients is really to more individualize the duration of treatment. Also, because it gives us prognostic information, it can help us to reassess the response to therapy in these patients. So for the ICU setting, the concept is a little bit different. So if you have a high-risk patient, he comes in with a suspicion of sepsis, we should always consider initial antibiotic therapy, and we should use PCT more as a guide as a monitoring guide and a guide to stopping of antibiotics if a patient has clinically shown a response and the PCT levels have dropped. So if we introduce PCT now in the trials to this type of patients in the ICU, patients with pneumonia, high-risk patients, what are the effects on antibiotic use? And so you see the same results now for the higher risk patients. Again, in blue is the control group, and in red is the PCT group. And you can see on the left side that for ICU patients with sepsis, all patients are being treated on admission to the ICU, but the effect of PCT-guided care is really a reduction in exposure to antibiotics by about 25% by early stop of treatment. And the effect in patients with pneumonia is even higher, it's around 40%. Again, most patients are being treated in the PCT group, but most patients have shorter courses because PCT provides us with a signal that we can early stop antibiotics. So recently, there has also been trials for the neonates and for children. And this is just one example of a very large trial that was just published in The Lancet a couple of weeks ago. And you can see the results are very consistent also in the very little patients with about a 20% reduction in the exposure to antibiotics. So interestingly, now also when you look at these trials, they also estimated costs of PCT versus cost savings in regard to antibiotics. And so if you translate these results from trials into a cost analysis, you find that the strategy of using PCT is actually a cost-saving strategy because the cost of PCT is much lower than the costs of antibiotics. But I think important to note here is that these results are only true if we really act upon the PCT results. So we should really include PCT into stewardship protocols, and we should really act upon the results and early stop antibiotics. Otherwise, the risk is that we will just measure PCT, we don't have a clinical consequence, and of course then we will not have any cost benefit for the patients. So let's go to our third bullet point. Does PCT-guided care improve clinical outcomes beyond that of antibiotic savings? And I think this very recent SAPS trial from the Netherlands has really changed the way we look at PCT in regard to outcomes. So this was a really high quality trial from the Netherlands. They included 15 hospitals, more than 1,500 patients, and the whole trial was done in a low antibiotic consumption setting. But still, PCT-guided care improved the usage of antibiotics by about 25 or 30%. So it was very similar to other trials. But this trial was also powered for mortality. And really, the investigators found that PCT-guided care reduced mortality by about 5% compared to the standard group. They also looked at the resolution of illness and found that PCT-guided care had a similar resolution of illness despite the shorter antibiotic courses, and this translated into improved survival of the patients. So in our meta-analysis, we also looked at mortality in all these different trials, and we found a very similar result. So if you look at the individual trials, most of them were not powered to show mortality differences. But when you look at the overall picture, also we found that mortality is significantly reduced if PCT is used for antibiotic stewardship. What do the sepsis guidelines tell us? And I think they have 3 statements in the sepsis guidelines which are very important and which reflects the data that I've shown you. So first of all, the sepsis guidelines suggest that measurement of PCT can be used to support shortening of the duration of antimicrobial therapy in patients with sepsis. So this is basically the concept of all these trials, that we use PCT as a monitoring tool, and once the patient has responded, and PCT has dropped, we can stop antibiotics and thereby shorten the course of antibiotics. Second, they suggest that PCT levels can be used to support the discontinuation of empiric antibiotics in patients who initially appear to have sepsis, but subsequently have limited clinical evidence of infection. So if you have a patient coming into ICU and you say, well, maybe it could be sepsis, so let's start to treat this patient with antibiotics. But on day 1 or 2, all the cultures come back negative and you don't have any real evidence for infection. And PCT levels remains low in such a patient. So then the PCT level can really help us to stop antibiotics in such a patient and not overtreat this type of patient. Now the third statement I think is also very important, because the sepsis guidelines also mention that any decision on initiating, altering or discontinuing antimicrobial therapy should never be made solely on the basis of any biomarker. So this is, I think, a very important point, and we should not see PCT as the new gold standard for our antibiotic management, but the gold standard is still the physician caring for the patient, making an overall assessment of the patient. The PCT is just another piece of information which helps the physician do better decisions regarding antibiotics. But it remains a clinical decision in any patient, and so we have to we don't have to overestimate PCT in this decision. I think it is an important tool, but we should see it always together with all the other tools that we have available. So also we have to realize that PCT has pitfalls. So it's not the perfect sepsis marker or infection marker such as troponin for myocardial infarction. We have to know PCT, we have to be educated about also the pitfalls so we can use it correctly in our clinical routine. So first of all, I think it's important to realize that the cutoff ranges depend on the clinical setting. So I have shown you the cutoff of 0.25 for the ER and the low-risk patients, and the 0.5 cutoff, which is used for the higher risk group for ICU patients, for the sepsis patients. Also, we know that false positives or false negatives can occur. So let's say we have a patient after major surgery, a patient after cardiogenic shock or major trauma. In these patients, you will find an increase of PCT, which does not point to sepsis, but it just points that this patient is very sick and he has just a cytokine storm-like syndrome. So if you want to use PCT in these patients, you should really only use PCT as a monitoring tool. And this is how surgeons also use PCT. They want to get a baseline after surgery, and they want to see a drop of PCT in the subsequent days. And if a patient has postoperative fever and PCT levels do not drop, this is usually a very clear sign that this patient could have a postoperative infection. Also, I think it's important that a single PCT measurement is really of limited value, particularly for inpatient care. So if you are in the ER, you have a bronchitis type patient, and you want to get an initial PCT level, which helps you not to treat this patient, I think an initial level is okay. If we talk about inpatient care, so here really the monitoring provides us with most of the information. And finally, PCT cannot give us any information about the bacteria. So we also need to look at the cultures, at the antibiotic resistance panels, and so on. So we have to see PCT as really a host response marker, but we also have to look at the pathogens. And I think if we do both, then we get most of the information, and it's most helpful for the management of our patients. I think another caveat is really that if we use PCT, we have to also use high sensitive PCT assays, because all these results from trials were done with high sensitive PCT assays. And so when we look at the different assays, I think it's important that the lower limit of detection and also the functional assay sensitivity is in the low range, so 0.05 around this, because if it's higher, we risk that we don't find subtle increases in PCT, and so the safety of really using these algorithms cannot be guaranteed. So I think it's very important that we only have high sensitive measurements in our clinical practice. Also, I think it's important that further studies are being conducted. So on the right side of this slide, you see different types of infections where interventional research has proven that PCT-guided care is actually beneficial for the patient and is safe. So particularly, we have the respiratory patients, so pneumonia, COPD, bronchitis, and we have patients with severe sepsis and septic shock patients in the ICU. So for these two populations, we have a lot of strong trial data. On the left side, you see other types of infections where we have maybe interesting observational data, but we are not 100% sure how to use PCT correctly for these patients. So let's say if we have a patient with endocarditis, I would not suggest to stop antibiotics after a week of antibiotics only because PCT has remained to normal levels. So it's very important, of course, that we know the limitations of PCT and we know the best field. And I think respiratory infection and sepsis are really the two major fields where we know exactly how to use PCT. So to conclude, I think PCT is a very helpful marker in the management of patients and particularly for antibiotic stewardship. It helps us in the initial evaluation, particularly to rule out infection in low-risk patients and also to establish the diagnosis of sepsis. Second, if we look at the kinetic of PCT, it's a very good monitoring marker which provides us with prognostic information, and it can help us to early discontinue antibiotics in patients, thereby reducing the overall exposure to antibiotics. And as we have learned from recent trials, it also improves clinical outcomes in patients. And so it's really initial evaluation, but then the monitoring which is most important for our patients with sepsis. So with that, I would like to close. I thank you all for your attention, and I think we should have a little bit time to ask some questions and to have a little bit of a discussion. Thank you very much. So I will read. I will start with the first question from Rita Curry. Can one elevated measurement be enough for diagnosing sepsis in suspected patients? And do you have to follow up with another measurement? Well, I think it's an important question. And really, the initial level, I think if it's high, it helps you to establish the diagnosis of infection in your patient. But more helpful than really the initial level is to see the kinetics. So I would always, for inpatient care, I would always recommend to do maybe every other day to do PCT measurements. And if the levels drop, this is a very strong signal then for you to realize that the patient, has responded. And also it helps you to better use your antibiotics. So I see in clinics sometimes that the physicians just do an initial measurement. But I think, having repeated measurements, that's really where you get most of the information. And so also in the trials, all these algorithms were based on repeated PCT measurements. So I go to the next question from Elizabeth Covington. Can you provide any guidance on the interpretation of PCT levels in the setting of renal dysfunction and/or congestive heart failure? Do you recommend higher cutoffs in PCT algorithm for such patients, or do you recommend to focus on findings and to guide antibiotic decisions in these patients? So I think this is also a very important question, because renal dysfunction has an effect on the PCT clearance. So typically, we don't find large differences in the baseline level of these patients with renal dysfunction, let's say patients with end-stage renal disease, but we find a somewhat slower decrease because PCT is cleared by the kidneys. So in the trials, really, the algorithms were not adjusted for renal dysfunction. But if in clinics I have a patient with end-stage renal disease and I see he's clinically responding, and let's say his PCT has dropped by 65 or 70%, and it's just a bit slower than other patients, I would still consider stopping antibiotics, knowing that in these patients, the whole kinetic is a bit slower. Now, your second part of the question regarding patients with congestive heart failure. So I think for this patient population, there is also very interesting research showing that PCT can help you to better assess the risk of a patient having acute heart failure versus pneumonia. And so different studies have suggested that the use of PCT actually improves your initial care, because if a patient has acute heart failure, you don't want to give this patient any antibiotics or any fluids, but you want to do the opposite. You want to take the fluids out of the patient. But if the patient has pneumonia, you have to give the patient fluids. And so having a negative PCT, a low PCT in a patient with acute heart failure, it helps you to rule out pneumonia and has also a strong effect on your strategy, on your treatment strategy. So let me go to the next question from A. Liapis. Can you please comment on some of the outcome data using PCT and sepsis and discontinuing of antibiotics, where the outcome signal was perhaps not as positive as has been seen in LRTI? Was that an issue of study selection and patient selection? Well, I think most antibiotic stewardship trials, the prospective trials, most of these trials have been positive. There were some small trials not reporting any significant results. I think then it was just a problem of power of the study. It was not powered to really show any benefit. And I think there is just one important RCT that has shown a negative result, and this is the Jensen study. And so the Jensen study is not really an antibiotic stewardship trial, but this study asked the question whether we could use PCT as a marker to escalate our antibiotic therapy. So in this trial, really patients were included in the ICU, and if PCT was high or didn't drop within 1 day, physicians were asked to do additional diagnostic tests and additional antibiotic therapies. And so really the trial was not very good set up, in my opinion, because they included a lot of post-operative patients where they had very high PCT levels just due to the surgical stress. And they also had a very short kinetic follow-up. So PCT had to drop within a very short time frame. And so this resulted just in an overuse of diagnostics and therapeutics. And the trial showed no difference in mortality. So by using more diagnostics and more therapeutics, the investigators could not lower mortality, but they found some problems with renal dysfunction and also longer stays in the ICU, just because of, using more and more antibiotics is toxic to the patient. So I think today we don't know how to really, how to use PCT for escalating therapy, because this trial was negative. But all the stewardship trials aiming to reduce antibiotics have actually been positive. So let me go to the next question by Lucio Lima regarding a decline in PCT levels of 80% or more, besides suggest a better outcome, does not making a suggestion to stop antibiotics too. Well, yes, I think, it is both really. The drop in PCT level, it really tells you that the patient is improving. So you may have, some consequences. Let's say you have a patient in your ICU and you consider to put him on a normal medical ward. And I think if the PCT has dropped and he's clinically improving, it's a signal that this patient has a really good prognosis. And second of all, it's also a signal for your antibiotic management, because if PCT has dropped to low levels or by at least 80%, it just tells you that there is no more ongoing infection and it's safe to then stop antibiotics. So it's really both. It can help you to better, to improve your site of care decisions, but also it can help you to improve your antibiotic management of the patient. So we have a next question by Catherine Davis. Why is PCT falsely elevated in patients with cardiogenic shock and post-operative patients, but it's not elevated in patients with a viral infection? Yes, well, I think it's an important question, and maybe the term false positive is maybe not the best term. It's just if you have a patient with a major activation of the cytokines, these patients, all biomarkers you can measure will be increased. So typically, if we have a patient with cardiogenic shock, this patient also has shock of his intestines, and usually we find translocation of bacteria through the intestines. So it is possible, and it has been shown that a lot of these patients have transient bacteremia, and also this leads to a very strong increase in PCT. So in the end, I think all these very strong cytokine storm-like syndromes, they lead to an increase in PCT. Now for a viral infection, let's say a viral bronchitis, you don't have a very strong cytokine release, and it's really more interferon gamma based response. And so we know that this response does not increase PCT as much. So I think that is why. So we go to the next question by Anthony Nasser. Is recent major surgery a contraindication for the use of PCT? Well, I would say it's not a contraindication, but I think it's important to realize why we're measuring PCT. So, I mean, you have to know that in a patient after major surgery, PCT will be increased due to the surgical stress. If you think the patient could have an infection and you want to get a baseline level, I think then it's fair to measure PCT as a baseline and maybe do it every other day. And so this is how surgeons use PCT. And let's say PCT is at 5 post-op, and it shows a nice decline, then it argues against an infection and shows the normal kinetics. But if then PCT doesn't drop, then surgeons take this as a signal that there is ongoing infection in this patient, and they may use antibiotics or do another surgery for such patients. So it's not a contraindication, but I think it's important to know that also that surgery causes a non-infection specific increase in PCT. So we have another question from Elizabeth Comington from Samford University. What if one level of PCT is low initially in an inpatient? Do you recommend a follow-up to confirm? So I think here again it should be the clinical kind of the clinical assessment that is leading. So let's say in my clinic, if we had a patient coming in with a COPD or a bronchitis type syndrome, and this patient has a low PCT level, we would not treat this patient. Now, if on day 2, let's say the patient, is feeling better just based on giving the patient a bit of fluids and maybe some, drugs against fever. If the patient is feeling better and his clinical status is improving, I would not do another PCT measurement. If, however, the patient still has fever on the next day and is not really looking better, then you can do another PCT test. And, because if you have a patient coming in very early, you may have an increase, within the next day. But the low initial PCT level argues against the relevant infection. So I would really look at the clinical situation first, and if you're in doubt, I would do another measurement. So there's also a question from Elizabeth asking how frequently we recommend monitoring PCT levels. So I think most studies really used a PCT measurement every 48 hours. So this is what we typically do in our institution. So we do a baseline when a patient comes in, and then we do it every 48 hours. I think if you have a patient that is not stable, a patient in ICU or a patient that is just not doing well, of course you can do also then daily measurements for just to be sure. I think as a general rule, probably the 48-hour is probably kind of a good timing for PCT measurements, and you don't overstretch PCT, but it still helps you to get the relevant information. And so also if after, let's say, 48 hours later PCT didn't drop, that's really then a signal that something is not correct in the patient. If after 24 hours you don't see a drop, you don't know whether the patient had another peak, and so sometimes it's more confusing if you have too many levels. So let me see. So there is one question from Vivian Osta regarding the value of PCT in pediatric patients. So I'm not a pediatrician, and so I'm not very I'm not really an expert to answer this question. But I think that the studies have been positive, and also for this patient population. And so I think PCT has a strong value also in kids. I think this recent Lancet paper from Stocker and colleagues looking at the neonate population has shown that PCT monitoring also helps to reduce antibiotics in this population. There is also studies on children that are a bit older, showing that, you know, it is probably helpful to differentiate between viral and non-viral infections. I'm not sure whether, you know, the cutoff may need to be adjusted a little bit compared to the adult population, but overall, I think it is a very helpful tool. So let me see if there is any more questions. Moses, yeah. There is one question from Robert Ortuno. I see the Moses study a significant reduction in mortality with a decline over 80%. Is there a percent decline we should be aiming for before making de-escalation for discontinuation recommendations? I would be apprehensive with a 5 to 10% decline versus 30% declines over 1 or 2 days, for example. Yeah, so I think the Moses study really was more a prognostic. It was more a prognostic study, and so for Moses, because it was an FDA trial, we had to pre-specify our aim, and so we had to pre-specify the 80% drop in PCT, and this 80% drop was based on other studies. And one retrospective study we did within 2 US hospitals. So this is why we focused the Moses study on this 80%. But of course, I mean, you can also look at shorter time courses over 1 or 2 days. We will also, within, you know, using the Moses population, we will also, you know, do some more statistical analysis to, you know, to answer the question, you know, like kind of what is the optimal decrease of PCT over 1, 2, or 3 days. But for this initial paper, we had to focus on the 80% because it was just our pre-specified kinetics. I think overall, I think, you know, 24 hours may be a too short time frame to really use PCT as a prognostic indicator. And as I mentioned before, the study done by Dr. Jensen, the PASS study, used a very short kind of kinetic. And so a lot of patients in his study, I think, were just overtreated because he didn't wait long enough for PCT to drop. So this is why I think for prognostic purposes, it's better to wait for at least 48 or 72 hours before, you know, really changing your management of the patient. Because in some patients, you will have an increase of PCT just due to the kinetics if a patient comes in, let's say, very early into the hospital. So let me see. There is one question by Catherine Davis. Has PCT been shown to increase in patients with sepsis due to fungal infections? Well, in fungal infections, we usually don't see an increase in PCT. And so if, let's say you have an immunosuppressed patient, he has fever, and he has a low PCT, I think fungal infection and also viral infection should be higher up in your list of, you know, of possible pathogens. So if you have a patient with fever and the risk for fungal infection, I think a low PCT would really increase the likelihood of this patient having fungal infections. Sometimes I've seen patients with very severe fungal infections involving different organs and so on. And in these patients, you can have then an increase in PCT. However, it's not so sure whether it's really the fungal infection causing that, or whether these patients are so sick that they have, you know, again, maybe translocation of bacteria through the intestines. And so because we don't have a good gold standard in these patients, typically, it's hard to understand whether, you know, it's the fungal or if it's a co-infection. But we would certainly, in such a case, you know, rather use antibiotics. And even though if we don't have, you know, even if cultures remain negative, we would rather use antibiotics in such patients. questions. So I think it is 3 minutes to 10, and I think we have gone through all the questions. I would like to thank you all for your participation and also for asking excellent questions. And of course, if you have any other questions or comments, you can always just send me an email, and I'll be happy to give you some inputs. So with that, I'd like to close the session. We will go back to ID week, and I hope you all have a good day. And thank you very much for your attention.